Hello, everyone, and welcome. My name is Peter Monteleone. I'm a interventional cardiologist and a vascular medicine doctor in Austin, Texas. I'd like to welcome everyone to this live webinar sponsored by the PERT Consortium and supported by AngioDynamics. Tonight we're going to be talking about advanced PE therapies, discussing mechanical thrombectomy, with particular highlights spent on blood management and some of the novel tools and strategies for what's really the next frontier of optimizing mechanical thrombectomy as well as advanced PE therapies by interacting with blood management, blood loss, blood return, all the above, including a focus on some novel clinical trial work, which has gotten going with the Apex Returns trial. So next slide for me. I'm going to be joined today, and we can go to the next slide, by my friends and colleagues, Dr. Brian Stegman. Brian's an interventional cardiologist at Centricare Heart and Vascular in St. Cloud, Minnesota. And then Dr. Sabah Butty, who's an interventional radiologist at Christus Health in Alexandria, Louisiana. So we've got a multidisciplinary panel, perfect for a PERT consortium meeting, and perfect for what we're going to be talking about. These therapies, these devices, these technologies, they've changed rapidly over time. We've seen strategies using catheter-directed thrombolysis, multimodal mechanical thrombectomy, novel techniques, novel therapies. As the devices have changed, so have the mechanisms of clot extraction or clot therapy and treatment. And we're going to be talking tonight about some case-focused discussions about thrombectomizing pulmonary embolism, particularly using the AngioDynamics AlphaVac system, talking about extraction of thrombus, also talking about blood management strategies to really try to optimize those results and those care. Now, I'll highlight at this point, there is a chat. There's a Q&A chat for all of us that's open. If you have questions, I, as your intrepid moderator, will be keeping an eye on it as we go through and making sure that we're asking some of these questions off to the group. Next slide for me. As all of us that have been paying attention to the world of pulmonary embolism have been made aware of, just in recent months, we've started talking about new guidelines for pulmonary embolism therapy. For a long time, we were, initially using these terms massive and non-massive and submassive pulmonary embolism. We emerged into some ESC 2019 guidelines where we talked about low, intermediate, high, and high risk. And just in past months, we've moved into these multidisciplinary 2026 guidelines, which actually brought some insight from the world of the shock guidelines and started talking about an A through E classification: subclinical, symptomatic with elevated severity, and then incipient cardiopulmonary failure or cardiopulmonary failure in general. It lets us speak with a more nuanced language about pulmonary embolism therapies. Now, without doubt, it's a little bit more complicated system than what we're used to. And I think we're all getting used to it as we go, stratifying things that we've called for a long time intermediate low or intermediate high risk and bringing in this new nomenclature. But as we move towards the next steps and really the next generation of what this field is doing, it's going to give us the chance to really discuss with a lot more nuance what our next steps are going to be. So let's go to the next slide. Immersed in these guidelines as well are recommendations for mechanical thrombectomy. Now, again, there is so many moving targets within the fields of clinical trials work for mechanical thrombectomy, but this is a good place for us to kind of kick off these discussions tonight about case-based decisions and optimization decisions for mechanical thrombectomy. As we talk about classes C2, 3, D1 to E1, certainly more complicated than saying low, and intermediate high. I like to look at this slide and slides like it and really work from the bottom up. So, you can start down at what we know. We know in some of these lowest risk patients, there's not a lot of data for doing advanced therapies. We know that. If you look at the second category from the bottom, we know that there's still benefits for systemic thrombolysis. And, there's situations where we still need to think about, not rule out something which for a long time had a class 1 indication. So you want to make sure that that remains in your armamentarium as someone that's working with PE. But as we get to these top 3 groupings, it starts letting us think really about where we've already seen and where we're going to continue to study optimized strategies for mechanical thrombectomy. So category E, where we're seeing patients who have incipient or ongoing cardiac compromise. These are patients where previously all we had was systemic thrombolysis, and now we start having opportunities for mechanical thrombectomy in optimized selected patients. In patients, whether they have incipient cardiac failure or in the categories that we've previously discussed as kind of intermediate high or even intermediate low, we're developing evidence in these patients as well. And so we have some non-randomized data, some low-level data that gets us to 2B categories for these. So with this framework in mind that we're all getting used to, there's really no better way than to dive into cases. And I think first up we have Dr. Stegman who's going to be talking us through. Dr. Stegman, as you get started on this, quickly, how are you integrating this spectrum already? Are you starting to? Have you started to use the language, or how are you incorporating it at this point?
Yeah. Yeah, so it's a work in process. We are kind of as a group, have been discussing this a little bit, trying to get our documentation up a little bit. I think to your point, it definitely adds nuance to the description of the patients we're dealing with every day. I think, it was we've all been looking for um, a little more discussion about, degree of hypoxia, degree of actual right heart failure that kind of isn't just defined by how dilated the ventricle is. There's a lot of things that, I think we were hoping for a little bit more descriptors and a little more nuanced way to study this. And I think the guidelines are going a long ways toward that. Getting folks to, talk in this language is going to be, it's not going to be overnight. It's a little more complicated. It's a little more nuanced. It's, definitely going to take us a while, at least as a group and as a hospital system, I think, to get there. But we're working towards it.
Well, why don't
All
we
right,
go
next
ahead
slide.
and dive into your cases, Brian? Let's hear it.
Yeah. So next slide, please. So just a brief introduction. Brian Stegman, I'm an interventional cardiologist at the Central Care Heart and Vascular Center in St. Cloud, Minnesota. Also director of clinical research in our pulmonary embolism program here. So I thought, next slide, please. Um, I thought for those who are not familiar with the AlphaVac system and kind of the differences in this system with mechanical thrombectomy than the others, it might be useful just to kind of run through a case and go kind of skin to skin, um, working through kind of my workflow, and I think that of many folks who use this. So this is a 78-year-old female we'll be talking about today. She presented to our hospital after a day of kind of shortness of breath and presyncope. Was actually out shopping with her family, got super short of breath and nearly passed out, had to sit down, kind of um, try to recover, tried to get back up and walk out of the store and had to again sit down with another presyncopal episode. Became very short of breath. EMS was called, ended up in our emergency department. And you can see her high sensitivity troponin was a bit up. Her D-dimer, or her D-dimer was up, obviously, and her BNP was elevated. I actually had a mildly elevated lactate as well. Next slide. So this is her initial CT. So we'll run through this. As you can see here in our coronal projections, there's a fair bit of clot burden throughout the right, really all of the branches of the right, and kind of near occlusion of the right lower branches. On the left, you see, again, a fairly significant clot burden, more posterior, but you can see why she would potentially be having issues. Next slide. Or sorry, next, yep. So this is our RV/LV ratio. So from the CT scan, measured at 1.5, so pretty significant RV dilatation to go along with her clot burden and her clinical story. Next slide. So her initial course in the emergency department came in, heart rates were in the 110s, required 4 liters of oxygen to maintain her sats above 90. Was normotensive with a blood pressure of about in the 120s, but did have an episode in the emergency department as well, where she dropped her pressures into the 90s and became a bit lightheaded, requiring a bolus of IV fluids. Her initial echo findings down in the emergency department again suggested moderate RV dysfunction with a RV/LV ratio on echo of 1.4 and an RVSP of 55. So, from a risk stratification perspective, if we're talking about the ESC guidelines, which is, you know, um, what we tend to kind of still talk in, but are moving toward the ACC guidelines, this would be an intermediate high risk. And in our new kind of ACCHA guidelines, it would be a D1. Next slide. So, like we do with all of these folks, I had a discussion with her emergency department providers as well as her hospital's team who's going to be admitting her and her family and kind of decided after discussing the options to proceed with mechanical thrombectomy using the AlphaVac system. Next slide. So just a couple brief overview of the features of the AlphaVac system. So you can see on the left, their funnel technology. So 33 French funnel on an 18 French cannula. Um, Utility of this, I think, a bit bigger aspiration orifice, and also allows it to entrain clot better with less of the lollipopping phenomenon that can be seen with some other thrombectomy devices. Um, there's the aspiration handle actually allows for a 10 and 30 cc pull, so you can pull less or more blood depending on where you are and kind of how you want to do the procedure. Allows you to try to minimize blood loss. I think the other kind of important and really kind of different part about this system than other systems is because of this kind of atraumatic funnel and because of the angulation at the tip of the catheter, it allows for really wireless kind of navigation throughout the pulmonary artery tree. And once you have the catheter in the PAs, generally do not require another wire until you take it out. Next slide. So moving on to our procedure. So this is our original kind of still frames of some DSA images from the PA-gram. So you can see on the left, the lower branches, kind of interlobar and basilar trunk, are nearly occluded on the right, and the TA has pretty significant clot burden. On the left, we can again see the clot burden that we kind of appreciated on the CT scan. And her initial PA pressure was 65 over 29 with a mean of 43, and a mixed venous saturation of 55 with an index of 1.9. I'm a little bit of I really focus on hemodynamics in the cath lab, and I think it's important to kind of understand what the RV function is by clinically, but also by the hemodynamics and just understanding how sick this person is, because there are times where you're a little surprised with what their index is. Next slide. So as I said, we'll just quick go through this kind of step by step. So this is sheath advancement. So took an angle pigtail into the right PA, exchanged that out with a woolly to a multi, placed kind of distally, changed for I use a super stiff wire. Others use other things. As you can see, the oversheath goes fairly easy, traverses the heart and into the PAs pretty well with just a little negative traction. I generally place the sheath up in the right PA, and then, as we can see on the left, basically place the funnel at the distal edge of the sheath and unsheath the funnel, bring our oversheath back to just above the pulmonic valve, and now we're kind of navigating without a wire. Next slide. So in this particular procedure, using our fluoroscopic markers, we're just navigating by advancing the catheter and counterclocking and clocking to get to where we really need to be. So in this procedure, I decided to go after the truncus first. So you can see me countering up into the truncus, took two 10 cc aspirations there. And then on our right frame, you can see limited angiogram up the truncus, demonstrating really kind of resolution of the vast majority of clot burden. Next slide. From there, decided to navigate down to the right lower branches, and you can see on our left pane, just advancing the catheter, directing it to the branches we need to go to. As I get more distal, I use 10 cc aspirations. As I'm kind of more proximal, I tend to use 30 cc aspirations. I know you'll get a little bit different views from different folks, but in this case, we used a few 10 cc aspirations in a little bit different areas in the right lower, and this is our kind of limited angiogram on the right. Again, demonstrating pretty good resolution of the clot burden. Next slide. So now we're switching from the right to the left. I switch myself to an LAO projection. I pull back the catheter, And as you can see on our left image, it basically just pushes itself over into the um, left side almost automatically just because of the anatomy. Um, Now I know I'm in the left. I'm in my LAO projection, and I'm advancing my cannula and aspiration funnel. Um, Initially proximally, taking some aspirations and then distally. In this particular case, we had a pretty good amount of clot on our first couple aspirations up proximally, but then we're kind of whiffing on our distal ones. Next slide. And so take a quick picture, and we see, yep, still have clot burden in our lower branches. So I just flip RAO. This is RAO 20, I believe, to give me some AP views of the PAs and appreciation. And you can see in our middle pane that um, I'm just a bit too anterior. So we're going to go more posterior, advance. And on our final box there, you can see the cannula, fairly easily, honestly, advances without really any hangups and pretty easily directable. We take some 10 cc aspirations, um, a bit proximal to begin with, and then distal. And what I didn't have on here is we took one quick fluoro shot that looked very good. Next slide. So now we're on that procedure. We're going to come back to our final picture, but I wanted to just demonstrate on this slide how you can transition from the right to the left and from the left to the right. So for folks who haven't done a lot of AlphaVac, our left image, you can see I started in the left PA, pulled our cannula and funnel back, redirected toward the right, and just pushed it out, and we moved pretty seamlessly. On our pane on the right, we can see that, what we just showed is that as you're pulling it back, it tends to want to go to the left and will flip over and can be pushed up to the left. All right, next slide. All right, so back to our case. So this is our still frame from our DSAs on our right PA. I tend to take the catheter out and put a pigtail back up there just to get our PA pressures and our another mixed venous sat, and to get myself a good angiogram if they have normal kidneys. I try to minimize dye during the procedure as much as possible, and would be, but this person had good renal function, so we took our last pictures, and you can see on the right, I kind of nearly just a little bit of distal clot that you can see on the right, and on our left, we have a pretty clean angiogram. Next slide. So this is our clot that we had removed. Next slide. And so how'd the patient do? Most important thing. So our post-aspiration hemodynamics, PA pressures went down to about 54/26 with a mean of 36. Mixed venous sat went up to 60. So our index was now about 2 liters per minute per meter squared. So we had some improvement in our index, even acutely. Procedure time about 35 minutes. I think Dr. Butty's going to talk a little bit about procedural efficiency. I really think that as we move forward in mechanical thrombectomy, really focusing on procedural efficiency and making these procedures as simple and as fast as we can is going to make for better outcomes in these frequently sick patients. And last thing but not least, pretty minimal blood loss. So we reinfuse or auto transfuse all of our blood through a hemodynamics filter. And now with which I think Dr. Monteleone is going to chat a bit about in the future. As we develop new reinfusion systems, hopefully that just becomes more and more efficient.
Brian, that's a great skin to skin discussion of how to do this. Dr. Buddy's going to be going through some differences between the devices and some comparisons and steps. You hit on a couple things that, in the spirit of the blood return discussion, I just wanted to kind of push forward even more that were a little technical. You'd mentioned, and I know a little bit about Dr. Buddy's thoughts on this too, which I'm going to ask the same question later, not to prompt, but the 10 versus 30 pulls. You'd mentioned you're sometimes using the 10 cc pulls distally and the 30 more proximal. How do you start? Do you start proximal and work distal? What are you doing? What are you doing with those pulls as a result?
Yeah. So I start proximal always and work distal. I tend to, and this is driven a little bit because I know I'm giving back all the blood. In the more proximal, larger arteries, I just go immediately with 30 cc pulls. Once I'm advancing past into the branches, I'll do 10 cc pulls for a couple of reasons. One is just being cognizant about the amount of blood you're actually taking. We're giving it back, but you never know what that means in the long term. But I think that the other issue is, and this goes for really any mechanical aspiration. As you get into smaller spaces, you tend to need a little less suction, a little less volume, and they tend to be a little more effective.
One of the other topics your videos do a great job showing off is that funnel, and as you're navigating particularly branches and distal branches, how much do you use visualization of the funnel? Because the funnel is going to collapse more, than your catheter. Are you using that visual aid as you're trying to get where you're going?
Yes.
Yeah.
So, as I'm kind of navigating the PAs and working through branches, I'm basically looking at two things. I'm looking at how the funnel's moving, if there's any collapse, and if there's any loading on the catheter back. So if my oversheath is moving a little bit back, I know I have some forward pressure on something. If I have any collapse in the funnel, I know I'm on top of something. You know, it, I was actually, I will be very honest. When I first used this system, I was very reticent to do the wireless navigation and was, very careful about it for the first many, many cases. And it's just something we don't do generally, but it does tend to advance, very easy. You just have to do it methodically and with purpose. But you get enough feedback visually and tactile to keep yourself out of trouble and to really understand where you are.
It's a great point. Cardiologists are used to getting their hand slapped if they even think about putting a catheter forward without a wire in front of it. Or some of our interventional radiology colleagues are a little braver and have helped us champion some of these movements. But that makes a ton of sense. And so, Brian, just to confirm, that whole case, your only rewire was basically putting the pigtail back up at the end to take a picture.
Yep,
Yeah,
leaving a woolly wire in
it's great.
for the pigtail.
Yeah.
Yep.
And even though it wasn't in this case, that movement from the left side to the right side, I mean, that's one of the big challenges in PE therapy. I think as we've trained, we all start on the right because big catheters like to flop over automatically to the left. And the ability to get back if you need to without a rewire, a reposition of a dilator, not only is that a time issue, but there's a traumatic injury issue, and there's also a bleed issue because every time you're taking dilators out, you're losing volume. So
Yep.
great cases, great skin to skin cases. Perfect segue into our next talk. So, Dr. Buddy, I'm super excited having seen some of this. Please take us away with your discussion. Next slide, if you would,
Sure.
on these comparisons and some of your own kind of internal data about what you've seen.
Yep. Next slide, please. All right, so this case is a 60-year-old female patient, 4-day history of dyspnea, quite symptomatic, not able to walk short distances without becoming winded. She has associated rib pain. Regarding her VTE history, has never had any prior events, has no identifiable risk factors, and has no family history of VTE. Next slide. If we look at her data, we have her physiologic data, vital signs, oxygen saturation 95% on 2 to 4 liters of nasal cannula. She's essentially normotensive and slightly tachycardic. Looking at her laboratory data, she's COVID negative, flu negative, and she has an elevated D-dimer, BNP, and troponin. Next. So this is a coronal view of the chest, and I think as we play through it, if you are able to do that, slide the cursor near the bottom of the screen. There we go. You'll see that she has a fair amount of embolic debris occupying much of the main pulmonary artery, and there's extension into the main left and main right pulmonary artery as well. It is definitely flow limiting. If you could play that one more time so the audience can see that. Oh, okay, maybe not. So anyways, this is really a still image, and the importance of it is if we look at the center of the image, this is really the ideal position for the oversheath or the working cannula, as I often will say, and that's the sheath through which the 18 French thrombectomy catheter goes through. The reason why this is the ideal location, it's really at the transition of the right ventricular outflow tract and main pulmonary artery. The reason why this is really an ideal position is the triple durometer engineering. In other words, the more of the catheter that's exposed, the more likely you are going to be able to navigate the pulmonary vasculature with ease. The more that it is within this oversheath, the less likely you're going to get the full effect of the catheter in terms of selectivity and being able to navigate the pulmonary vasculature without a guide wire. Next slide. So this first slide is really, as you will notice, we're pointed to the right, and my intention is to go to the left pulmonary artery. And I typically, when I'm working on the left, I'll go on a left anterior oblique. If I'm working on the right, I do the same thing, right anterior oblique. But I wanted to show this to you because it's with relative ease that you can advance from right to left. Now, if we look at the next slide, and as I'm advancing the catheter, I'm actually doing 10 ml aspirations. Now, once I've gone into the left, I will also come back and sort of sweep the lingular and left upper lobe segments. And so that's what that was trying to show. Next slide. Now, one of the areas that can be difficult to get are the medial segments of the left lower pulmonary lobe. And if we just leave it right there, you can see that the AlphaVac device is able to reach those areas, which are typically harder to reach with guide wire-based devices. And if we look at this, you can see that the catheter maintains its shape and it allows you to get very distal into the hard-to-reach areas in the left lower pulmonary lobe. And you can see that there's no catheter kinking. You essentially have two 90-degree angles, and you can see how far distal we are. Again, we are able to navigate the pulmonary vasculature with ease, and the key is the triple durometer engineering, as well as the positioning of the oversheath at the junction of the right ventricular outflow tract and main pulmonary artery. So now that, this case is a little different because we dealt with the left side first. As the other moderators suggested, they deal with the right side first. But this is really showing how easy you can navigate the vasculature right to left or left to right. So we've done the left. Now we're going to go to the right side. Next slide. So in this, we're directed to the right. I'm going to oblique the II, and I'm going to go into the right lower pulmonary lobe. And you'll see, again, we can get very distal into these hard to reach areas. And if we just freeze it right there, and if we look at this, this is a really important image. Again, pay attention to the oversheath. We're at that junction, the RVOT and main pulmonary artery. You can see that we have essentially a 270-degree angle here. There's no catheter kinking. The other thing that's very important for those that have done some of these procedures, you'll notice that on the right side, the right interlobar artery distally, many times will have a downward angulation, almost like a 90-degree. And again, being able to torque this device and being able to get that funnel directed downward will allow you to thrombectomize those distal segments more effectively, more cleanly, compared to guide wire-based thrombectomy devices. So we're able to deal with the right lower pulmonary lobe, right middle lobe, and then if we go to the next slide, one of the more challenging areas that can be difficult to access with these procedures is the right upper pulmonary lobe. And again, you'll see here, this is in real time. It's just a matter of seconds before we'll get into the right upper pulmonary lobe. So here we go. Now, it'll be there in a second. And if we look at it right there, you can see that's perfectly positioned to thrombectomize, which probably is one of the hardest areas to clean when it comes to these procedures. So in these fluoro loops, I was able to show you how we can approach the right and left lung. I have shown you where it can go. You've seen the CT scan that we had when we started. So now we have to say, okay, we've seen what it can do. Let's see what kind of result we have. So if we go to the next slide and we look at an angiogram, and this is from the main pulmonary artery, and I think we have a fairly respectable result. And one of the things that I would like you to notice about this, if we play it one more time, is that there really isn't much in the way of peripheral clot. And I think this is something that I've noticed with the AlphaVac device compared to competitive devices, is that funnel tip technology, the ability to select, allows you to engage those segmental vessels distally and allows you to apply maximum cross-sectional area suction to those areas, which you're really not able to do with the same efficiency and effectiveness as you could with AlphaVac. So in general, my completion angiograms tend to look cleaner, particularly in the peripheral segments. And I think that's one thing that's very noticeable using AlphaVac compared to other devices. Next slide. So you've seen what we've done. You've seen the angiogram. The question is, well, how did we get there? And what happened during the case? So I think in terms of blood loss, I think for me, I think blood loss is an expected thing with these types of procedures. And I think as long as it's expected and manageable, then I think it is okay to not necessarily replace the blood. And we'll talk about that in a second. But our blood loss here was 175 milliliters. If we look at our systolic pulmonary pressures pre and post intervention, I think we had a very good response. And the procedure time, this is from puncture to closure. And I think it's very important to think about when we talk about procedure time, because others may talk about inhuman time, device time, suction time, but this is from beginning to end, 37 minutes. Next slide. Next slide. So one of the things that I think about when choosing a thrombectomy device, I really have to go back to basics. What are my goals? You know, I have, in my mind, I have primary goals, secondary goals, and tertiary goals. My primary goals, I want to remove as much embolic debris as possible and as quickly as possible to provide the right ventricle some physiologic relief. My secondary goals, I want a device that can be quite effective and have procedural efficiency. And if I have those first two goals, then my tertiary goals become easier to meet. And my tertiary goal is regarding blood loss and blood return. And we'll talk about my thoughts with that on the next slide. So if we talk about blood return, in my mind, blood return should be really thought of as an enhancement to a procedure and not a necessity of a procedure. Because if blood return becomes a necessity of a procedure, then there's a certain reality that we can't avoid. It's suggesting that the device itself is very inefficient. And so, you know, blood return, and that's why I say should be enhancement, because if it's a necessity, then we're compensating for, you know, a downfall of a device, or maybe a feature that we can improve or would want to have better. The other thing we talk about in terms of blood return, we'll find out with the apex return, is really the quality of blood that we're returning. And once again, blood loss, when we think about it, is it truly harmful? I think if it's expected and manageable, it generally is not harmful. And so for me, it's not the end all be all. And I think sometimes we have too much discussion about blood loss. Next slide. So one of the things that I have to think about when I think of AlphaVac is that, you know, it really is a new class of thrombectomy catheters. And we have to start categorizing these thrombectomy catheters, because as we become more mature in terms of trying to tackle this clinical problem, we're going to want more from our devices. And not all devices are equal. And the reason why I say AlphaVac is truly in a unique class is that there are two things that are going to set it apart. The idea of how you're performing thrombectomy and the idea of how you're engaging the clot. So with AlphaVac, thrombectomy is performed by selection. And if I can select, my blood control or my blood loss is controlled. And if I can select, my device is more efficient. And because I tend to use the 10 ml flow rather than the 30 ml pull. And the reason for that is I am able to get more attempts at thrombectomy, 3 more attempts with 3 10 pulls versus 1 30 ml pull. Now, if we look at the suction power difference between the two, if I am using a 10 ml pull, the suction power is 13.8 pounds per square inch. If I'm using a 30 ml pull, the suction power is 14.2 pounds per square inch. So with the 30 ml pull, it's a little more, but I don't really think it's worth it, because now if I do 10, I'll get 3 more attempts at getting more clot out. It's like having more numbers to win the lottery. The other important thing to think about, and I think Dr. Stegman had mentioned it, is the handle. There is no other device that allows you complete control in terms of blood loss. I control the blood loss. I'm not at the mercy of a syringe. I'm not at the mercy of a vacuum. It's when I pull that trigger or I squeeze that handle, that's the blood loss that the patient's going to have. Now, if I'm on the 10 ml pull, the maximum amount of blood that I'm going to lose is 10 mLs. But if I'm also collecting clot, I'm definitely going to lose less than 10 mLs per squeeze of that trigger. One of the other things that's important, we talked about selection And I think that your ability to thrombectomize is more efficient if you are able to get right up to that clot. And I think, if we look at guide wire-based thrombectomy devices, it tends to be by proximity. In other words, we're putting that device in this area. I don't have the ability to select. I don't have the funnel. I'm applying massive amounts of suction to get that clot out. But there are problems when you do that. And I think the key is when you have the funnel tip technology that gives you the greatest cross-sectional area of suction on the clot, and you have selection, you don't need massive amounts of suction. What that means is that if I'm having localized thrombectomy, the physiologic changes that are happening in the pulmonary vasculature are quite small. I really don't want to have rapid volume and pressure changes in a patient who's already not doing well. And that can be the danger of some of these guide wire-based systems as opposed to the AlphaVac system. Next slide. So one of the things that I wanted to do is really, and this was my own curiosity, because I was so pleased with how the device was working, I wanted to compare the early outcomes of my AlphaVac experience and compare that to my most experienced level using the FlowTriever device. So this was a single center, single user retrospective comparison. And I was focused on procedural efficiency and hemodynamic outcomes. And we'll talk about how we got these 42 patients, but it was in my first 42 uses of the AlphaVac compared to my last 42 uses of the FlowTriever T24 device. And the FlowTriever device, at that time, I had performed over 400 FlowTriever cases. Next slide. So again, it was a study. We were a high volume PE center where I had performed this study, and FlowTriever was our primary device since 2018. And really, we just wanted to know, could AlphaVac match or exceed the outcomes of FlowTriever, even during my initial experience? Next slide. So again, retrospective study. I looked at the first 48 AlphaVac cases and compared it to the last 68 FlowTriever cases. They were consecutive cases. And after excluding cases with hybrid device use, incomplete pressure data, non-thermal access, or concurrent procedures, confounding fluoro time, we came up with 42 AlphaVac cases, and we did them between September 2024 and April 2025, and then 42 FlowTriever cases, again, June 2024 and May 2025. And they're all done by me. And if we look at the severity of these patients, for the AlphaVac cohort, we had 2 massive and 40 submassive. In the FlowTriever, we had 3 massive and 39 submassive. And we were looking at fluoro times and PA systolic pressures, as well as the 30-day all-cause mortality. Next slide. So this is what we came up with. Fluoro time. It was a bit shorter with AlphaVac compared to FlowTriever. If we look at our PA systolic pressure reduction, again, it was greater with AlphaVac compared to FlowTriever. And if we look at our 30-day mortality, it was less with AlphaVac compared to FlowTriever. Now, because of the sample size, some of these numbers weren't necessarily statistically significant, but there is a suggestion that the steerable cannula and wire-free advancement and maneuverability contribute to procedural efficiency over the FlowTriever technique. And of course, I think it's worth further investigating this with a prospective study. Next slide. So with the AlphaVac system, again, I think it's very important that we start differentiating catheters, because the other competitive devices, the main competitors, they're drastically different, and I believe that there are limitations. And I think the advantages of AlphaVac is that we have selection. There is no other catheter that allows you to do that. We have the ability to navigate the pulmonary vasculature with ease without a guide wire. It allows you to focus on doing the procedure. When we compare it in terms of moving parts and complete control, there are fewer moving parts or fewer procedural steps using AlphaVac compared to competitive devices, and the ability to continually thrombectomize rather than having to stop, start, filter, listen to a vacuum, listen to a computer telling you what to do. That isn't happening. With AlphaVac, there's a lot of feedback that's occurring real time, understanding what the funnel does, understanding what the collapse and splaying or non-collapsing in the funnel is, and looking at your barrel chamber near the handle. You're getting a lot of feedback in terms of what's happening during the procedure. Have you cleared that portion of the pulmonary vasculature that you're targeting, and is it time to move on to different areas? So there's real-time feedback. And then the other important part that we have to realize is that the funnel tip technology really plays a tremendous role. when we think about this, my experience has been that you really don't run into a lollipop instance or situation. The funnel tip technology, the importance of it is that we are applying the greatest amount of suction power per cross-sectional area to engage that clot compared to other devices. So your ability to engage, ingest, and have a high degree of procedural efficiency is very likely with AlphaVac compared to other devices. And lastly, we know that the wireless navigation is safe. This proprietary tip technology has been present for over 15 years. We've used it in angiovac, we've used it in the heart, we've used it in the SVC, the IVC, without concern. The other thing that we should think about is, this idea of selection without a guide wire for the interventional radiologists and the cardiologists out there who are doing, aortic-based procedures, whether they be in the iliacs, the renals, the mesenterics. Many times we're selecting those vessels without a guide wire. So we know this concept of selection without a guide wire can be done safely. If the device is appropriately engineered, it can be done safely. And I think for AlphaVac, it is the right device for the pulmonary circulation.
Dr. Butty, that as a tour de force, that's a great overview and explanation. And it's rare to see someone having effectively documented their first use of a device like you did with this work. Like you mentioned, you were comparing kind of your last cases, with a previous device to your first cases with this device. And so in addition to giving you a comparison, it also kind of shows us a little bit about what the new user experience really is like with this. During those early cases, what changed? How did your use of AlphaVac change over time? You mentioned some of the things you do now. Did that all start right away?
Yeah, so I think the two things that I learned early on is the value of doing 10 ml pulls versus 30. Again, the more attempts that I have at thrombectomy, the faster the procedure is. And it's like winning the lottery, like I said. I just have more numbers to win the lottery. And knowing that the suction power difference is quite negligible, it just made no sense for me to do the 30 ml pull. That's the first thing. So in that sense, more is not better. The other thing that I realize is the positioning of the overshoot, the 22 French device that sits at that junction, the RVOT and main pulmonary artery. That was really the key to really understanding and embracing the ability to navigate the pulmonary vasculature without a guide wire. And in that situation, more is better. More of that thrombectomy catheter that is exposed or unsheathed, the greater your ability to navigate the vasculature, and your efficiency goes way up. You learn to appreciate the ability to select. When you have it constrained or you have it in anything but that position, you might be a little frustrated with the device. So those are really the two most important things for me. And again, this idea of wireless navigation, the thing that we should think about, we're really, in a way, it's not the funnel that is leading. What's really leading is that triple durometer engineering, the varying degrees of softness on the 18 French portion of the device. And what's really happening when we navigate the pulmonary vasculature is that portion of the catheter, the 18 French, that's what's really driving the catheter, because what it is doing, it's riding off the most cranial aspect of the pulmonary artery, and that's what's allowing us to advance. And then the one-to-one torqueability is what's allowing us to select. So in a way, you're sort of leading, but maybe not with the funnel. There's a lot more action that's happening behind the funnel that's allowing you to do these things.
And Dr. Butty, before we move to the last talk, my talk, there's a quick question from the crowd, which is a very good specific one. As someone that's leading with 10 cc pulse for all the reasons you mentioned, is there ever a time where you're up front doing a 30?
No. I mean, I tried 30 in the beginning. I tried it in the beginning, and it didn't add anything to the procedure. You're free to use it, but I think, again, what is going to make the difference with this device? Cross-sectional area, suction, that's the funnel, and selection, and it's a localized thrombectomy. So it is the selection in which I think is the real key. The one thing that I would say is that I think maybe perhaps a little bit of a myth is that when we do these procedures that we need massive amounts of suction to clear the clot. And I think that is probably a little bit of a myth. You don't need massive amounts of suction. As we do more of these procedures, we're going to have to expect more from our catheters. We can no longer just have an end-hole catheter and a bunch of suction. And if And if that were the case, then there is no reason to develop any other catheters. There is no need to really want anything more from our devices. But that's the farthest thing from the truth. We want devices that have procedural efficiency. We want devices that improve safety. We want devices that allow us to get the maximum amount of clot out within the shortest period of time. And so we have to change how we engage clot. We have to change the tip of these catheters. End-hole catheters are sort of a little archaic. And so that's just my opinion. So they're a little bit, there's more to this procedure than just the end-hole catheter. The reality is that it is selection and the size of the thrombectomy catheter, which are important. But you definitely don't need massive amounts of suction. If you've done other cases, you know that a slow suction will also allow you to ingest the clot as well. So it's not these rapid, quick changes in volume and pressure that are going to deliver. And in fact, those types of things can be very detrimental in a patient that's very tenuous.
Wonderful. Well, thank you so much. Let's go on to the next slide. So it's a great segue. As we talk about device technology and the actual catheter, the next step in blood management is talking about the actual concept of blood return. And that leads us to this Apex Return trial, which is onboarded and moving forward to answer this question about the next frontier, really proving safety, effectiveness, and what we're doing when we're retransfusing removed blood. Next slide. So you've seen this slide before, right? This is just tying it to Dr. Butty's talk. When we think about thrombectomy, we're thinking about taking clot out. We're thinking about physiologic relief from what's going on with that clot. We're thinking about doing it quickly and doing it effectively. But then there's also this somewhat imperfectly understood concept about how blood loss matters and why we need to initiate strategies which are proven in order to effectively perform it. Next slide. So blood management, we break into these categories. There's blood loss, and you've heard a lot tonight already about ways this catheter, not the blood return system, but the catheter is optimized to allow that. If you're not doing 100 wire exchanges, if you have a funneled tip that's allowing you to get distally exactly onto clot, if you have the ability to use 10 cc pulls as opposed to 30 cc pulls, you can really just minimize blood loss. Then there's the blood return concept, and I'm going to show you a little bit of data about what happens as we start getting more and more aggressive with thrombectomy and extend cases. We got to think about what's being returned. Blood return kind of showed up on our shelves as we were doing these cases, and when to use it, what it's really accomplishing, what we're returning in terms of the quality of blood, and how efficient it really is hugely important. So next slide. So we obviously have a lot of clinical trial data in the pulmonary embolism space and in the device space. This lists some of the devices between AlphaVac and FlowTriever and Penumbra and the Bashir catheter. We're not really looking as a primary outcome at blood loss. We're not differentiating what's happening to patients when they bleed or when they don't. We know that a lot of these devices and catheters are successful in reducing RV to LV ratio from baseline to 48 hours. We know that there's good safety in terms of freedom from major adverse events. We know there's some variation, but there's effective clot burden reduction. When we look at modified Miller scores, and you can see the AlphaVac with 35% reduction in clot burden, one of the highest that we've seen in some of these procedural cases. Next, please. The trials aren't done there. So we've now emerged into the space of randomized control trials. Randomized control trials also aren't necessarily diving into this blood loss component. That's really why it's the secondary step. We'll always get some bleeding data, but we don't necessarily know how well bleeding patients versus non-bleeding patients do. Just at the ACC meeting, the HyPitho trial, landmark randomized control trial, the ECOS catheter versus anticoagulation alone was presented. Shows us that these therapies can help benefit patients, particularly with hemodynamic decompensation. Peerless 2 actively enrolling mechanical thrombectomy with FlowTriever versus anticoagulation alone. STORM-P with the Penumbra device was looking against anticoagulation alone and demonstrated benefit in some of these interim parameters. The P-TRACT study actively enrolling right now. We're going to be continuously getting and gathering data that helps push these guidelines that we've already seen from February into the next generation, but there's a lot of work to be done. Next slide. And some of that is what we're learning about bleeding. And bleeding right now has been restricted to the space of kind of non-randomized data in terms of what's happening and what the results are. There's this really interesting trial that's quoted quite frequently in JVIR, retrospective data, and it's looking at what's happening with 3 groups: catheter-directed lysis patients treated with catheter-directed lysis, patients treated with large bore aspiration thrombectomy without blood return, and then patients treated with autotransfusion. it didn't really show a difference between those groups, which is quite interesting, because for a long time people thought any TPA caused more bleeds, and thrombectomy was a way to avoid bleeding. And then once blood return came back, folks kind of assumed that we solved bleeding by just giving the blood back. If we go to the next slide here, you'll kind of get a sense as to what these three groups look like. So on the left is catheter-directed lysis, in the middle is aspiration, a mechanical thrombectomy without blood return, and on the right is aspiration thrombectomy with blood return. Even when you're returning blood, your hemoglobin is still dropping. Your post-procedural hemoglobin is dropping. Your hemoglobin nadir is dropping. Why? Well, something that we saw in this data is that people are just doing a lot more pulls when they have the ability to return blood. We haven't really optimized that pathway yet. And if you feel safer because you're returning blood, you're going to keep taking blood out. That's probably part of it. But the other question that comes up is how effective really is the blood return that we're doing? We don't have great answers to that question. Next slide, please. We presented this data called the real PE data, which used the Truveta population. Looked at basically everyone treated with catheter-directed thrombolysis with the ECOS catheter, mechanical thrombectomy treated with the FlowTriever catheter, across 100 million patients treated. So it looks at a couple thousand patients. Now, this is certainly not randomized data, but this is data using a modern AI integrated system that lets you look directly into partner member records. And what we saw is comparing exact matched patients, 980 patients treated with FlowTriever, 485 treating with ECOS. Next slide for me. We see more bleeding with mechanical thrombectomy than we do with ECOS, catheter-directed thrombolysis. That's an important thing to think about because historically there were these questions about TPA causes bleeds and mechanical thrombectomy doesn't cause any bleeding. That really starts to open up these questions about how do we minimize and optimize bleed risk. Next slide for me. When we presented real PE, and I'm sure the same thing happened when that JVIR data was presented, the question comes from the crowd of does bleeding matter? We put it in parentheses or in quotation marks because it's kind of an interesting question to ask out loud in 2026 about does bleeding matter? I don't have really direct data about what happens with bleeding in pulmonary embolism treatment patients treated with mechanical thrombectomy. We don't have that data yet. This is still a fairly young field, but go to the next slide. But we know that bleeding matters to everything, literally everything else. And when you start thinking about correlates, if you think about coronary artery disease and you think about procedures to treat it, so percutaneous coronary intervention or PCI, if someone bleeds, if someone has a major bleeding event in the setting of their PCI, without a doubt, by any study ever done, they have a robust increase in mortality. If you have to transfuse those patients with blood after PCI, they've got an even worse, risk of increased heightened mortality. That's kind of obvious. We assume that for PCI, but when we're thinking about pulmonary embolism, we're thinking about patients reliant on oxygen carrying capacity, patients who are hemodynamically compromised. And so why would we not think that bleeding mattered? Obviously it does. Next slide. If we move away from the coronary space and just think about endovascular or vascular procedures in general, if you look at patients treated with lower extremity procedures, bleeding also matters. Bleeding also drives these incredibly increased risk of morbidity, kidney injury, renal failure, and mortality kind of across the board. If someone needs a blood transfusion or if someone bleeds significantly, it's a very real phenomenon. Next slide. And so that's why blood management is so important, controlling blood loss through the mechanisms that we discussed, and then reinfusion of lost blood. And you can see the system that's used with the alpha return system in the middle. It's that same collection bag, and then there's a high flow blood return filter, and then a 60 cc syringe to reinfuse that blood. Next slide. We're studying that system because of the fact that we do these cases. And so there's three quick cases. We can go 1, 2, and then 3, where you see patients who are very decompensated. Next slide. And you'll see pretty extensive thrombus burden, kind of matching up similarly and next slide for me again, matching up similar to some of the cases that were performed. There are patients that were D1s here and sicker. And so the ability to take extensive clot out and return blood and prevent bleeding is hugely important. Credit for a couple of these cases, Dr. Rob Shutt, who's here in Austin, Texas. Next slide for me. This is where Apex Return came from. So Apex Return is an investigational device exemption study where we're looking at this alpha return blood management system. 12 sites, 39 patients to be enrolled. Myself and Dr. Suki Basra, Memorial Hermann, kind of leading this trial. And we're looking to move this trial quickly and answer this question quickly. Next slide. The inclusion criteria is similar to what we've seen for Apex AV and for other pulmonary embolism trials. We're looking for patients with RV to LV ratio that's enlarged, patients who are not critically ill. These are not the classic high risk, D1, D2E patients, but we're looking for patients that are intermediate high risk patients, similar to what's been enrolled in other trials, including Apex AV. Next slide. As such, there's also certain exclusion criteria. Now we're thinking about blood loss and blood return here. So in addition, we're being thoughtful about baseline platelet counts and baseline anemia, and also making sure we're not looking at the critically ill patients that might be suffering other issues, including heparin-induced thrombocytopenia, which might change or impact what we're seeing with blood return. But go to the next slide. But the most important piece of this, as we're looking at our technical endpoints, right? This concept of, are we able to successfully return blood through the alpha return system? We're also looking at the same safety endpoints that we look at with these device technologies in mechanical thrombectomy, and then go to the next slide. But then the key is we're looking at blood return. So you'll see these laboratory assessments of blood quality at 3 different steps. Go to the next slide. So those 3 steps, first is at baseline. So we want to see what's going on with patients and at baseline within 48 hours of them actually undergoing the procedure. Then we're looking at the returned blood quality. And this is a very different assessment from what we've seen previously. Basically, this is real blood about to be returned. It's blood that's been aspirated through the catheter with clot coming with it, which is per routine, put through the alpha return system into the 60 cc syringe that's going back into the patient. And then the last step is, before we're re-infusing all of it, we're taking a sample to check it. And then there's a post-procedure clinical assessment, blood sample number 3, which is looking 48 hours after the procedure. Next slide. And what we're looking at with all of these blood samples is we're looking at the foundational testing for hemolysis, blood counts, LDH, haptoglobin, but we're also working collaboratively with our hematology teams to look at these other tests for really the physiologic consequences of blood trauma: platelet activation, coagulation activation, inflammation, end organ effects, the things that happen when you lyse blood and then return blood. And so that's going to help us see baseline and then comparison to the actual reinfused blood. So important. Not just blood put through a filter, not normal blood through a filter, blood pulled out of the patient, put through the filter and about to be returned. And then blood 48 hours from the patient to see what's going on clinically. And next slide. And so from this, we're going to really start to understand for the best first time what's going on with this second key component of blood management, something we all do every day. What's happening with blood return in patients? Without doubt, as we've heard all night, these therapies have transformed clinical care for PE patients. We've learned that the catheters have gotten better and seen some of the specifics, whether it's the funnel, the ability to do differentiated pulls between 10 and 30 cc's with the AlphaVac catheter and device. We've seen some of these differentiating characteristics that Dr. Butty spoke so eloquently to about how we have come to expect more from the catheter we're using to extract blood. But as of now, blood loss is really still incompletely understood. And what we're doing to actually return blood remains incompletely understood. And so Apex Return, I think, really is going to be the tip of the spear for helping us answer and solve some of these questions. And so it's part of why we're also excited about the trial. It's why we're also excited about this new frontier of studying blood management in these really critically ill, sick, advanced PE patients. And so with that, that's my last slide here. So, for Dr. Stegman and Dr. Butty, it's been an absolute pleasure. If you guys have any closing thoughts on where we're moving, with these technologies or these trials, I'd love to hear them.
Yeah. One quick thought. I think, Dr. Butty talked a lot about this, and Peter, you spoke a lot about this. I think that, part of the importance of getting through these procedures and kind of really improving procedural efficiency is making sure that, the sick patient gets in and out of the cath lab or your IR suite as fast as they can, with a minimal change to their physiology as we can, conceivably give them. So, that's part of why I've kind of always thought that, as we develop these technologies, looking at blood return is going to, be very important for moving from what we are now to moving to hopefully what we will be, in the next 5-10 years. And, hopefully, I think AlphaVac system has done a lot to improve procedural efficiency by allowing selection of various branches, allowing wireless navigation, and allowing a little bit more nuance in how much blood you're actually losing with your aspirations. But I think, as we go forward, if we can, continue to improve and really understand how to do that, this work is going to be paramount in really kind of getting us to the next level.
It's a great point. Dr. Butty, closing thoughts in our closing minute.
Yeah. So, I think with many endovascular procedures, there's always an evolution. And, we start out with devices that really make us interested and really legitimize procedures. And I think that's what the end-hole devices, syringe-based devices, vacuum devices have done. But as we accept this as being a first-line therapy for PE, the reality is that we want more. We want more from our catheters. We want them to be able to become more efficient, more usable, and safer. And so in order to do that, we have to move away from this idea of proximity-based selection, and we have to move to selection. We have to move to clot engagement. But when I say safer, we have to think about not just the mechanics of it, but the physiology. What are we doing to the vasculature? And what are we doing to the mediastinum as well when we put the stiff guide wires in? Because as we anatomically change the mediastinum, put forces on the mediastinum and the right ventricle, we're altering the physiology. So I think there are many reasons why the AlphaVac system is really taking us to where we need to be, at least getting us thinking different about how we approach these procedures. So at the end of the day, we're always going to want more, and we have to really change in how we approach it and how and think and refine the technique over and over so we can get these procedures done quickly, safely, and get these patients back to where they were before the embolic event.
Wonderful. Great closing thoughts. I think we all are maintaining high expectations about the future of these technologies. So thank you all so much for being here and joining us tonight. Thank you to the speakers for helping lead us through this technology. Thank you to the PERT Consortium for sponsoring this. And of course, we look forward to seeing everyone on the webinar at the upcoming 2026 PERT meeting, September, I believe, in Boston. So thank you guys all for being here and have a wonderful night.